Primary sclerosing cholangitis. Etiology, pathophysiology, and pathology. There is diffuse inflammation and fibrosis involving the whole of the biliary tree, eventually leading to obliteration of bile ducts and biliary cirrhosis with portal hypertension. The disease usually involves the intrahepatic ducts alone, but there may also be involvement of the extrahepatic ducts, and occasionally the disease is limited to these. The etiology is unknown, but the disease is probably immunologically mediated. Primary sclerosing cholangitis, PSC, is strongly associated with coexisting inflammatory bowel disease, especially ulcerative colitis, and also with HLA-DR3. Antibodies to paranuclear antineutrophil cytoplasmic antibody are nonspecific but seen in 60–80% of cases. Epidemiology. Prevalence is 6 per 100,000, 70% are male, and the average age at diagnosis is 40 years. Clinical presentation: fatigue, intermittent jaundice, pruritus, right upper quadrant pain, or no symptoms but abnormal liver biochemistry, often noted in patients with ulcerative colitis or Crohn's disease. Physical signs. There are no signs in about 50% of symptomatic patients. Jaundice and hepatomegaly or splenomegaly may be present. Investigations. Liver biochemistry. High alkaline phosphatase and gamma-glutamyl transferase. Mild elevations in serum transaminases, aspartate transaminase and alanine transaminase. Bilirubin may be raised. A low albumin and raised prothrombin time are only found in late-stage disease, biliary cirrhosis. Cholangiography. Percutaneous transhepatic cholangiography or ERCP show multiple irregular stricturing and dilatation, beating, of intrahepatic ducts, Fig 41, with or without extrahepatic stricture. Liver biopsy. May be normal. Periductal onion skin fibrosis and inflammation with expansion of portal tracts, bile duct proliferation and portal edema. Late progressive fibrosis with loss of bile ducts, Fig. 42. Differential diagnosis. Secondary sclerosing cholangitis due to cytomegalovirus or cryptosporidium infection in AIDS. Previous bile duct surgery. Bile duct stones causing cholangitis. Post-liver transplant recurrent PSC is hard to distinguish from biliary stricturing secondary to hepatic arterial ischemia. Treatment. There is no curative therapy. Management of complications. Antibiotics, e.g. oral ciprofloxacin, which is excreted in bile, for cholangitis. Well-defined extrahepatic biliary strictures can be stent or balloon dilated at ERCP. Ursodioxycholic acid. Improves liver biochemistry but probably has no effect on histology or survival. Steroids, azathioprine, methotrexate, and cyclosporin have not been shown to have any effect on disease outcome. Liver transplantation. Indicated for end-stage biliary cirrhosis. Cholangiocarcinoma is a contraindication. Complications. These include cholangitis, common bile duct or intrahepatic stones, extrahepatic biliary strictures, biliary cirrhosis with portal hypertension. Cholangiocarcinoma occurs in 10–30%, more commonly if the patient has ulcerative colitis, and colorectal carcinoma, 25% lifetime risk, especially if the patient has ulcerative colitis. Most of these complications present as increasing jaundice. Prognosis. This is variable. In symptomatic patients, the median survival from presentation to death or transplantation is 12 years. 75% of asymptomatic patients are alive at 15 years. Disease associations. Between 5 and 10% of patients with ulcerative colitis and 1% of those with Crohn's disease develop PSC. Up to 70% of patients with PSC will have clinical or histological evidence of ulcerative colitis. The colitis may predate the diagnosis of PSC or present many years later.